صباح الخير. أنا دكتورة سورة عبد الوهاب, subspecialty neonatology, and I will present to you principle of enteral feeding in preterm infants. This lecture will be half an hour today, presented in the Children Welfare Teaching Hospital, presented to you, and I will hope you will get benefit of it. First, I would like you to write your name in Arabic for all of you. Scan the code and write your name, please. Yes. Keep your mobiles silent. Yes. And if you have any question at any time, you can ask freely. Okay. Yes. I will present to you the introduction of enteral feeding, energy requirement, initiation of enteral feeding, advancement, use of fortification, use of feeding schedules, and also the nutritional assessment and discharge planning. These are the learning objectives of the lecture of today. At the end, you will be able to describe the nutritional requirement, apply an evidence-based strategies for advancement and initiation, and analyze feeding tolerance, evaluate different feeding strategies, and design an individualized feeding and monitoring plan, including the discharge and follow-up nutrition for the premature infant. First, I will start by this picture, and I want you to discuss with me. What do you understand from these photos? What you eat here, you will feed here. What's this?
Yes, that's importance of feeding for neurodevelopment.
Yes, especially for a premature infant. The feeding of a premature infant is very important to prevent the extrauterine growth restriction, and later on the neurodevelopmental impairment, which is occur as a main complications of these extrauterine growth restrictions and main complications for premature infants. So first we will start by introduction. The premature infants have a greater nutritional requirement, as you know. They have a higher metabolic rate, and a provision of an adequate nutritional support to this premature infant remain a challenge in our neonatal intensive care units. Among the extreme premature infant, duplicating the rate of neutero growth remain an elusive goal. And postnatal growth failure remains a common complication of a neonatal intensive care unit. So first we will start by the energy requirement. As you know, that energy requirement for any person is equal to the resting energy expenditure plus the energy which is required for the activity done by the body, like the feeding, fecal procedure, and heat loss. All these need an energy. So the energy requirement will be the sum of both the basal, the resting energy expenditure plus the energy required for this activity. And this energy requirement will be different between the term and also between the from the preterm infants. For the term infants who are aging between 8 to 63 days, it's about 49 to 60 kilocalorie per kg per day. This is the resting energy expenditure. Regarding the premature infants, this is the estimated energy requirement for a premature infant. And as you can see that the resting metabolic rate is about 40 to 50 kilocalorie per kg per day, plus the other energy required for other activities for these premature infants. Besides that, you know that for enterally fed premature infants, they require more energy than those who are parenterally fed premature infants. For enterally fed, it's between 110 to 130 kilocalorie per kg per day, and for parenterally is between 90 to 100 kilocalorie per kg per day for infants who are less than 1.5 kg. This is also, as you know, because of they don't need they don't expend the energy for the fecal loss or the other activities related to feeding. And for the infants with the chronic illnesses, like for example, those who have an bronchopulmonary dysplasia, they will require an energy more than the other preterm infants. The nutritional goal of the enteral feeding is to achieve the rate of growth that are the rate of growth and the nutrient accretion that match those achieved by infants similar gestational age in utero. As if we are imagine that this preterm infant still they are in utero, so that we need to give them the energy requirement and also the nutrient accretion like they are still in their in utero. So let's discuss when we can initiate the enteral nutrition, when, what, and how. If you have any idea about that, I will give you some papers and ask you to write your answer here for a few minutes. Yes. Yes. Write your thoughts about that subject. I will take the papers at the end of the lecture, okay? So, we have either early initiation of enteral feeding or we have a late initiation. Early initiation means that the feeding can be started in the first 6 to 48 hours. And the late initiation, the feeding which is started after 48 hours from the delivery. Both of them have an advantage and disadvantage. Regarding the early initiation within 6 to 48 hours, it's found that it will improve the outcome, including the reduction of the number of days of parenteral nutrition, reduced risk of necrotizing enterocolitis, reduced rate of late onset sepsis, while the delay of the enteral feeding is found that it is decrease the cell proliferation in the small intestine, decrease the superior mesenteric artery blood flow, and also it will increase the apoptosis. So the first feeding which can be started is the colostrum. As you know that the oropharyngeal swabbing of the colostrum is very important and can be started early within the 6 hours after birth. It's improve the immune system for these premature infants, and also it is help in the initiation of breast feeding and expression of the breast milk from the mother. The other type which can be started within early initiation is the trophic feeding, or what is called also as a minimal enteral feeding, gut priming, minimal enteral nutrition, or what is called as a hypocaloric feeding. These are small volumes of milk, typically 12 to 24 ml per kg per day, without advancement in feed volume during the first 3 to 7 days of life. Some points about the trophic feedings. This feeding is started in the first day of life, ideally within 6 hours. If the medical is stable, can be given by the orogastric or nasogastric tube. Use of unfortified mother-owned milk, breast milk. If it is not available, so in this case, you will give the donor pasteurized human milk for those who are less than 1.5 kg. And for those preterm premature who have no breast milk, you can start the premature formula, especially if he is stable and he is more than 1.5 kg. Trophic feed also, it's important to know that it can be given to the infant with umbilical venous or arterial catheter, also infants who are undergo the treatment for the PDA. Before I will pass to the advancement of enteral feeding, is that clear, or you have any question about the subject for initiation before we will go to the advancement of enteral feeding? No questions?
For 3 to 6 days without increasing.
Yes, it is called as an yes. Any gestational age, but later on when I will talk about the advancement, it will be yes, earlier. We can start earlier, and it's advised to be started earlier. There is some graph say that, or some studies say that not initiating enteral feeding is bad, but initiate atrophic feeding is better than not initiating. And rapid advancement is better than trophic feeding.
Too much sex.
Yes, yes, yes. يعني مثل ما نقول احنا هو انه تبدي بهاي السمول اماونت better than بدون. Yes. بعدين yes, according to the studies, advancement early within 48 hours or 24 hours is better. Yes. Regarding the advancement, the time of advancement, a numerous study and systemic review suggest that minimal enteral feeding is superior to no enteral feed, but not better than earlier advancement. Yes, of enteral intake. Current guidelines recommend starting with a small volume enteral feeds, example 10 to 30 ml per kg per day as soon as possible after birth in most preterm infants, and to advance feed as clinically tolerated. Yes. And in stable preterm infants, where the clinician considers that the feed volume can be increased, a routine daily increment of about 18 to 30 ml per kg per day is recommended, especially in those who are on breast milk fed infants. I think that's the answer. Yes. About the rate of volume increment, the feeding protocols can help to achieve or to decide the rate of increment of this breast milk, and such protocols will be differs from one center to another. But the accumulating evidence suggests that feed to be advanced more rapidly than previously thought for infants who are healthy and show no signs of feeding intolerance when used in the context of the carefully managed protocols. And this is one of the example of the guidelines for feeding advancement in newborn infants with a birth weight of about 1 kg and 1.5 kg. And of course, as you know, that each center should have their protocols for their milk advancement and not to restrict to the others. Regarding the feeding schedules, some schedules are advised to increase the or to give the feeding schedule every 2 hours, some every 3 hours, and some studies found that advancement or the schedule that is 2 hours every 2 hours is better to reach a full enteral nutrition, and less days of parenteral nutrition. Early discharge from the NICU is more or is better than those who have schedule every 3 hours. And both of them have no increased risk of necrotizing enterocolitis, as you know. And this is also another example about the suggested feeding schedule for infants in the neonatal intensive care units. Regarding the mode of giving this feeding, those who are less than 1 kg and 800 gram can be given the enteral feeding by the nasogastric or by the orogastric tube. And this is could be continue until the premature infant show their readiness to take an oral feeding, which is usually occur between 32 and 34 weeks of gestation. And later we will talk about the signs of readiness for the oral feeding for these premature infants. If there is no any question about that part of advancement, I will go to the fortification of this breast milk. No question? Okay. About the human milk fortifier, as we all know that breast milk is the best milk, and it's a proper milk for given all the nutrient and energy requirement for all newborn infant. But regarding the premature infant, still it is the best, but it cannot achieve the energy and the nutrient requirement to achieve the good growth for these premature infants. That's why there is an something or substances that is added to the breast milk to increase their caloric and nutrient content of this breast milk. This is called as a human milk fortifier. You can see that according to this table, the nutrition that provided by the unfortified human milk and by the premature formula. And on the other side, this is the nutritional needs for these premature infants. That's why we said that the breast milk alone cannot achieve this nutritional requirement for these premature infants. That's why we should add the human milk fortifier. This human milk fortifier can be either a bovine derived human milk fortifier, or could be a donor human milk fortifier, and even there is a donkey milk derived human milk fortifier. Yes. But this donkey milk fortifier is only present in Italy, and it's also presented for a short period of time and done or used for studies only, and then after that it is not used actually. And regarding the forms of this human milk fortifier, it can be either presented in a form of liquid form, or it can be presented in a form of powder form. Of course, we prefer the liquid form because it has an less contamination and risk of sepsis. Regarding the fortifier, also could be either a multi-component fortifier, or it can be a single nutrient supplements. This is the different type of products that can be used to fortify the human milk, either in a form of multi-component fortifier, which can be either a bovine milk derived multi-component, or it could be a human milk derived multi-component fortifier, could be single nutrient, that's to say supply a single nutrient, either a protein or fat. These fats also can be a medium chain triglyceride, or can be a long chain fatty acid, or it could be an carbohydrate also, could be a glucose polymers, or could be an maltodextrin. Or as we use here in our center is the use of a premature formula as a fortifier. These premature formulas could be either premature, or could be a PDF or post-discharge formula, that's to say give either 22 22 calorie per kg per day, or can give a 24 calorie per kg per day. So, where the time to start the fortifier? Anybody know?
Per ounce.
Yes, per ounce. Yes.
When you reach
160.
60 milk per
60 milk.
Yes.
60 to 80.
Yes.
Enteral feeding?
60 قسم 100.
Yes.
86.
Yes.
60 is هو 60.
Yes. Yes, that's right. Yes. This is according to the type of the fortifier used, whether it is an bovine derived or it is a human milk derived fortifier. If it is an bovine derived human milk fortifier, so in this case, some centers start the fortification when they reach about 100 ml per kg per day. And some centers may reach, when they reach about 60 ml per kg per day, they start fortification for this human milk, if they are a bovine derived. And but there is an limited evidence suggests that this is safe to start early on 60 ml per kg per day. And regarding the donor human milk derived fortifier, start fortification when the enteral feed reach about 60 ml per kg per day, and some centers even started earlier when they reach about 20 to 40 ml per kg per day. And the experience and limited evidence from several studies suggest that early introduction of an fortified feed is well tolerated when using an all human milk diet. That is to say, the human milk derived fortifier added to the breast milk. It is safe to start even earlier when they reach about 20 to 40 ml per kg per day. Yes, yes. If it is a human milk derived fortifier. Yes. Yes, safe. Regarding the target volume for this enteral feeding, the target volume for feed is to reach about 160 ml per kg per day of a fortified human milk. This target volume generally supports a weight gain of about 15 to a 20 gram per kg per day. And in some neonatal intensive care units, they can even reach up to 180 to 200 ml per kg per day. And there is some evidence that this target volume yield a great increase in the weight, length, and head circumference without adverse effect, and in those healthy preterm more than 1 kg. If there is no question, I will pass to the monitoring and assessment. No question? Yes. Okay. Then after we started initiate advancement and did fortification for this milk, we need to assess this nutritional supply and also to monitor this nutritional supplementation for this premature infant. Of course, the monitoring will be by the growth parameters and by lab investigation. So first, by the rate of growth, as you know, that weight should be taken daily. And the weight increment which is accepted for premature infants for those who are less than 2 kg is about 15 to 20 gram per kg per day, and for those who are more than 2 kg is about 20 to 30 gram per kg per day. Also, we will monitor the length of these premature infants, and the daily increment or the accepted increment or target is about 1 cm per week. And for the head circumference should be assessed weekly, and the target is about 1 cm per week for this growth parameter. The growth parameters are charted on the gender-specific charts for this premature infant, and our aim is to attempt all these parameters above the 10th centile for the age and for the sex of this premature infant whenever possible. Regarding the laboratory monitoring, also we will do an hemoglobin, calcium, phosphorus, alkaline phosphatase later on, as you know, on the 5th to 6 weeks of age with alkaline phosphatase, blood urea nitrogen, and the alarming is when blood urea nitrogen is less than 10. This means that suggests that there is a need for more protein intake. Serum electrolyte also is important in selected infants, those receiving diuretics, feed unfortified human milk, or they have a limited intake or have a slow growth. So, when a premature infant can feed orally, this is another part, and I need to hear your suggestion. When they are ready for oral, yes, yes, yes. I said that they should be ready for oral feeding, and this is usually occur between 32 and 34 weeks gestation, correct gestational age. Plus, there is some signs that infant should be transitioned from a gavage to an oral feeding when a physiologically capable to do that, not based on the weight or the gestational age criteria. This is very important, that we will start the oral feeding not only depending on the gestational age, but also on the physiological stability of the premature infant himself. So, an infant is deemed stable for introduction of the enteral feed when they have first not have a persistent physiological decompensation such as bradycardia or desaturation. When handled, the infant is handling his or her own secretions and show a sucking behavior on a finger pacifier or an empty breast. These are the physiological signs which are important to start the feeding despite his gestational age. Of course, the discharge planning after they started oral feeding, we should plan for their discharge of these premature infants. Usually, we start to plan for the discharge when they reach about 50% of their target or a full oral enteral feed, and to consider the discharge from the NICU when a premature infant is maintained his body temperature outside the crib, and meet both of the following. They feed on any one of these type of formulas, either exclusive breastfeeding or breastfeeding added to it and a premature formula or post-discharge formula. Or they have a standard diet, that's to say those formula, regular formula, or they have an enriched diet. We mean by it is a post-discharge formula, which is supply 22 calorie per oz, or the higher calories, about 30 kilocalorie per oz. And in addition to that, they have an established growth rate on the one of the above feed. That is to say, they have an increasing weight, about 50 to 20 gram per kg per day. Infants more than 2 kg have a gaining weight of about 20 to 30 gram per day. After that, we should continue on the follow-up of these patients by monitoring of their growth chart after discharge, and also the electrolyte, and to also to interfere when there is any abnormality of these growth parameters or electrolyte for these premature infants. At last, we have the summary and take-home message. A growth failure and extrauterine growth restriction is one of the most important complications of a premature infants and can cause a neurodevelopmental delay. And breastfeeding is the best feeding type for term and premature infants. And preterm infants have a higher energy requirement and nutrient requirement. That is why a human milk fortifier should be added. And growth parameters and lab monitoring should be continued for these premature infants after they are discharged, and to interfere as early as possible if there is any problem for their growth. And lastly, your feedback is very important. Please scan the code and give us your feedback about the lecture. Yes. And thank you very much. If you have any question, I'm ready. Okay.
If he is 34 weeks gestation,
Yes.
okay, and his body weight is 1.5 kilo,
Mm-hmm.
and he is taking full oral feed per once. He is taking oral. You want to discharge him? You'll discharge him without NG,
He is fully on oral feeding.
but his body weight is 1.5 kg.
Yes. According to that, يعني no, I will discharge him on NG. Yes, with NG, oral and NG. Yes, both of them. But of course, I will check if he has any problems with the weight gain, like a preparation of the formula, he has anemia, for example, or other type of formula used, number of feed given per day.
He is ready for discharge, but the
Yes.
question is, he can take 1 ounce oral.
Yes.
But shall we discharge him without NG? This is
Yes. I think I will discharge him by NG and oral. Yes.
Thank you.
Yes. Thank you. Thank you.